So the big debate is which induction agent to choose when we're talking about severe ANCA-associated vasculitis, organ-threatening disease. And so we have the two main drugs that we use, which is cyclophosphamide or rituximab.
That's Dr. Arielle Mendel. She is a scientist at the Research Institute of the McGill University Health Center. She is also an assistant professor in the Department of Medicine, Faculty of Medicine, and Health Sciences, McGill University. She's a rheumatologist at the MUHC. Her research focuses on patient safety in systemic autoimmune rheumatic disease with an aim to improve medication safety. We are thrilled to have her as our guest on this episode of Around the Room to talk about management of ANCA Vasculitis. She was the first author on the CanVasc consensus recommendations for the management of ANCA Vasculitis 2020 update, so I can think of no one better to speak with us about such a complex topic. Welcome, listeners. I'm Daniel Ennis, and a warm welcome back to my fabulous co-host, Dr. Janet Pope. Janet, how are you?
Good, and welcome everyone listening, and hi, Daniel.
And thanks for making it here. We know you're always busy and just finishing up clinic, so thanks for joining in. Now we can get on with the show and our guest, Arielle. Welcome to the show. How are you?
Hi, I'm doing great, thanks. Thanks for having me.
So we've actually known each other for a long while now. Do you remember when we actually met?
I think we were summer students in Toronto, CRA summer students at Toronto Western.
That's right. I think you were at the Western and I was at Children's.
Oh, okay.
Yeah. So we've kind of known each other for a long time and crossed paths in our careers, and then we both did our vasculitis fellowships together. So I happen to know on a personal level that you're an excellent clinician and quite brilliant. So I'm really happy that you could be here to chat with us. So enough pleasantries, Arielle. Quit stalling. We're going to get down to business. So today we're going to talk about ANCA vasculitis, and actually we're going to skip discussion about diagnosis because there's just so much to talk about in ANCA vasculitis management. And just for listeners, for clarity, we're going to focus on GPA and MPA, and we'll have to have you back to discuss eGPA another time, but kind of a whole different body of literature addresses eGPA. So I'm hoping just to kind of set the table, we're going to...
Sounds good.
Perfect. So we're going to break down the conversation into kind of standard phases of treatment. So maybe into induction and maintenance and duration of therapy. So let's take induction first. When you have diagnosed a patient with ANCA vasculitis, how do you determine the right induction treatment for that person?
That's a good question, and it's always evolving. These days, we always look at the patient in front of us and think, well, would I say this person has severe ANCA-associated vasculitis or less severe ANCA-associated vasculitis? And for me, to be less severe, if they have what we would consider limited, so sinonasal otitis, maybe orbital disease, but no, destructive sinus disease, I would say, and definitely no organ-threatening disease. That would be sort of in a different category for me. And if we're talking about anything that's even involving the kidneys, even in a minor way, lung involvement, pulmonary hemorrhage, or interstitial lung disease, large cavitary lesions, I'm thinking this is more severe. We also think about, how systemically unwell is the patient? Are they hospitalized? Are they losing weight?
Mm-hmm.
That sort of thing, can help me decide as well whether I need to be sort of aggressive with the induction immunosuppression. And that, really when we say induction, we mean, the goal is to get them from this state of having very active disease into a state of remission. And we sort of define that as absence of any vasculitis disease activity, which is sort of a little bit arbitrary and based on the clinician to decide what they think about whether the disease is active or not.
Mm-hmm.
So that's what when we say induction, that's what we're talking about, is this period of transitioning from very active untreated vasculitis where, back in the day when we didn't have these treatments, the mortality of ANCA-associated vasculitis was basically 100%, to now where we are actually addressing the inflammation and the vasculitis and getting everything under control, and hopefully they're asymptomatic. So the big debate is which induction agent to choose when we're talking about severe ANCA-associated vasculitis, organ-threatening disease. And so we have the two main drugs that we use, which is cyclophosphamide or rituximab. And cyclophosphamide actually comes in two flavors. You can give it orally or you can give it IV. And I think that most of the time it's based on where you're living and the access you have to intravenous infusion clinic. We know that probably oral cyclophosphamide, you get a higher cumulative dose of cyclophosphamide. So that comes with more infections, but maybe a little bit more effectiveness or efficacy. Those trials were done, though, before we had really solid maintenance agents like we have now. So I don't think, based on what I can say right now, that you would need to choose oral cyclophosphamide over IV, given that we have such good maintenance agents.
And I want to spend quite a bit of time talking about those induction treatments. So that's a really excellent kind of intro and table setting from you. Back to kind of just determining severity. You gave us some really important kind of bedside tips for how to determine that. And what I got from what you said is it is okay to, as the clinician, see a patient and decide, you don't have one necessarily a life-threatening thing, but you can still have severe disease. So just because you're not about to die, that is not the only thing that determines severity. So I think that what you pointed to was you can have a kind of organ-specific manifestations that you feel are that you as the clinician, you'd say that's severe because that organ is being badly damaged. And then I was hoping that you could maybe reflect a little bit on the 5-factor score and whether you use that as a determination of severity, or is that or do you just use that as it's an interesting tidbit that tells you about prognosis, but I don't use it at the bedside? Is it something that you integrate into your decision making?
That's a very good question. I have to say I use it more when I'm thinking about PAN and eGPA, which is a little off topic. The study that derived that score included those patients, as well as patients with microscopic polyangiitis. And, I think that we have data that if you use that score to decide whether you give somebody steroids alone or cyclophosphamide, that the treatment goes well. But we haven't taken somebody with one of those 5 factors, so bad kidney disease with protein or with a high creatinine, cardiomyopathy, GI or central nervous system involvement. We haven't taken those people and randomized them to just get steroids alone or cyclophosphamide.
And we would never do it, right? We would never do it.
Yeah, although, for eGPA at least, we are, they have been doing the trial looking at rituximab versus prednisone alone for a non-severe eGPA, which is interesting. Anyway, we don't have to talk about that. We can cut that part because I know you're not focusing on eGPA.
Next time, we'll discuss that next time. That is actually interesting. Yeah. So the 5-factor score really, you think that is derived from eGPA and PAN. The revised 5-factor score deals with the kind of broader ANCA vasculitis group plus PAN, but isn't really used quite as a decision-making tool because it kind of includes things like age and the absence or presence of ENT involvement, which aren't really going to be that you don't just treat someone with cyclophosphamide just because they're 70 years old. So it's a useful prognostic tool, not as much a bedside decision-making tool for the diseases we're talking about today. Is that kind of fair in terms of where it slots into decision making?
Yeah.
Okay. And
I think you've put it very well, Dan.
Thank you. I'm curious and I want Janet's take on this as well, is something that comes up with relative frequency in these diseases is mononeuritis multiplex. And I have certainly seen other clinicians kind of treat that as, if you have it, that kind of counts as like almost a 5-factor score of 1. I know we're kind of setting that score aside, but just to kind of make the point that it's a severe manifestation, even if it doesn't predict mortality, it's such a bad morbidity that it should kind of jump you into the severe group. And maybe here we can start with Janet. If like, how do you use that as a decision-making tool up front?
So there's mononeuritis multiplex, and then there's mononeuritis multiplex, right? So some mononeuritis is polyneuritis. It's mononeuritis multiplex in multiple areas. So fist, ankle drop, a foot drop, a wrist drop, etc. Those people, if they're not eGPA, where it seems to heal better, in my opinion, and I think other people have probably shown that by EMG nerve conduction studies, that they get better faster. If we're talking GPA, then I would say that in general, I would give the big guns. And it might be rituximab for many people. It could occasionally be Cyclo. And also, not always, but it might be accompanying other problems anyway, where you'd say their factor score, if we're going to look at it, is high enough already. If they have lung involvement that's clinically relevant, or renal, and their mononeuritis multiplex, they're going to get the big guns anyway. But in general, I would say, and then we'll hear what Arielle would say, if you have GPA and you have real mononeuritis multiplex, not a interesting stocking glove neuropathy, which might be mononeuritis multiplex of multiple nerves, but might not be, but real sensory and motor involvement, I would give stronger treatment than say azathioprine or leflunomide or methotrexate with the glucocorticoids. I would go to either Cyclo or Ritux, depending on the rest of the situation. Arielle, what would you think in something like a mononeuritis multiplex GPA patient?
Yeah, that's what I tend to do. If it's a true foot drop, wrist drop, I give cyclophosphamide or rituximab, with the knowledge that we haven't proven that giving cyclophosphamide for that manifestation is better than giving prednisone alone, but we feel better about it. And I always tell patients, this might not reverse the foot drop that you have now, but we're trying to prevent it from moving to another limb and causing the same problem. Mm-hmm. And, the other thing that patients often ask is this numbness, is this burning pain going to go away? Is my strength going to get back? And can't always say that right away. But I think we feel better knowing that we're giving them the best possible chance we think we're giving them the best possible chance of recovery if we're using what we consider to be the most aggressive immunosuppression.
Okay, so that's very helpful. So we kind of have a general sense of how we determine who is severe and who's less severe. Anyone who we didn't just talk about is kind of like the less severe. They still have the disease, but they don't have high mortality risk or organ-threatening disease or very high morbidity. Okay. So you've already given us kind of the primer on cyclophosphamide and rituximab, and totally unfair question, but is one better than the other? Are these equivalent treatments? We can't always access rituximab up front here in BC. So we often end up inducing with cyclophosphamide in various forms. And I'm wondering if, as an expert on the topic, you have an opinion on that.
I think we have to go back to the trials. So the only trial that has really compared rituximab on its own to cyclophosphamide was RAVE. The RAVE trial published in 2010, and they used oral cyclophosphamide. So that might be something to keep in mind when you think back to the studies that had compared IV and oral cyclophosphamide. But in that study, they didn't show that there's any difference in the primary outcome, relapse-free remission at 6 months, I believe is what it was, whether you got cyclophosphamide or rituximab. they did some subgroup analyses where, post hoc analyses where it looks like if you have a high risk profile for relapse, so you have PR3 positive or you've had a prior relapse, maybe you do better with rituximab compared to cyclophosphamide. If we're looking at the very short term induction, can I get somebody to that point where I can say you don't have any active disease? Mm-hmm. At 3 months is usually when we start thinking about saying that somebody's in remission. Mm-hmm. I don't think that we can say that one is better than the other. There's been, observational studies that have looked at this question in patients with severe kidney disease, more severe than what was included in RAVE. And it also doesn't seem like there's any difference in outcomes. So my feeling is that, if you don't have another reason not to give cyclophosphamide, which for me, the biggest thing is inducing premature menopause or inducing infertility. So basically anybody over 50, I really don't think that there's usually a strong argument to give one over the other unless you invoke this thing of, well, they're PR3 positive or they've had a prior relapse. Those arguments might be fair. I've often wondered, if I've had a patient with a prior malignancy, any malignancy, maybe that's another reason why I would lean towards rituximab. And I see more and more, we're often kind of making excuses of why rituximab might be used instead of cyclophosphamide. It's slightly more convenient because if you're giving IV cyclophosphamide, that's more infusions and, actually maybe better for the environment to only be giving 2 IV treatments, right? So,
yeah.
Arielle, can I just follow up on that? So whether it's IV or oral, I guess my Cyclo compared to Ritux, I guess, what do you think of the timing? Because, of course, if someone's really sick, you're going to tell us about Solumedrol or the high-dose glucocorticoids as part of induction. But if someone's really sick, what concerns me occasionally is the time it might take to sort of know, is rituximab a go, no-go on its benefit? Because it's really not 2 weeks, although the Solumedrol can be days to help. But rituximab's about probably 8 weeks, 12 weeks in some, not for any effect, but for sort of maximal effect. So I do see, and maybe it's a site thing or an Ontario thing, I'm not sure, but I do see sometimes people, they're in hospital, they get their first dose of Cyclo, and then we're not doing now maintenance, we're still doing induction with switching them to Ritux as an outpatient. And the thing that I hear everybody say is, well, timing. We can get Cyclo working and then switch them over. Are we maybe a little bit misinterpreting data, or we just gestalt clinically in Ontario, or is that sometimes that what either of you see being done sometimes?
I know at my center, I do have that sense, although I don't know if anybody's proven that there's a different length of time for cyclophosphamide or rituximab to take effect. Sometimes when we have somebody who's really sick, I do think about doing more of a RituxVasc protocol, which is published at the same time as RAVE, and they included people with more severe kidney disease. And so I guess they weren't comfortable giving people only rituximab, so they gave people rituximab plus 2 shots of IV cyclophosphamide, and they compared that to just getting only IV cyclophosphamide. And patients' outcomes were similar. So if I have somebody who's, really sick, or they have, really bad pulmonary hemorrhage, and I feel like maybe it's better if we just give them up front what we think might be a more rapid onset immunosuppression, that might be a situation where I deliberately, not because we here in Quebec don't have access to rituximab in hospital, but, I might stagger them, give some cyclophosphamide, then the next week a dose of rituximab, then another dose of cyclophosphamide, and then another dose of rituximab. And you might think that that's a lot of immunosuppression. I think in the grand scheme of things, maybe not. And I feel comfortable giving it because there's a trial where that regimen was used.
That's a really interesting approach. I think it comes up not infrequently, especially in ICU patients. I think it's incredibly odd that we actually don't totally know how quickly the medications work, right? We can tell how quickly you get cytopenias from IV Ritux, or sorry, from cyclophosphamide, right? Nadir is 10 to 14 days, done, fine. That's not necessarily when it starts working on kind of the more microscopic cellular level. That's not necessarily when it turns off the disease, but it is when we start to deal with side effects. So I think we sort of internally feel like it works faster. I know nephrology out here feels that it works faster. And I wonder if that's more because we start to see those cytopenias rather than that it actually works faster. I don't know if either of you have a comment on that, but it's a perennial issue of, oh, it's been 5 seconds since we gave the Cyclo and they're not better yet. Should we switch to Ritux? You're both quite experienced in this. Is there what do you set as your, Arielle, you've given a good thought, which is you can always just combine them. And there are a number of regimens that combine Cyclo and Ritux. But maybe we can start with Janet on this one. Do you have a goalpost for when you say, if they have not started turning the corner by X week, then I will switch them. I will swap their therapy to, if I started with Ritux, I'll swap to Cyclo. I started with Cyclo, I'll swap to Ritux. Do you have a gestalt there?
Right. First, it's anecdotal. Secondly, the time to flare in the RAVE trial. That's different than the time to getting your remission, which seemed like it was about the same, but the outcome was, I think, time to flare. It was sort of the same timing to flare, right? The graphs are superimposed. So I guess if I look backwards, was the time to getting better the same too? I'm not sure, because they were looking at remission as well as time to flare. So with those caveats, I mean, where I would say is I don't think it's fast enough or good enough is my anecdotal approach to pulmonary hemorrhage, high mortality. That would be one case where they're still getting plasmapheresis here, in addition to whatever else we're giving them. But let's put that aside, because that is an anecdotal subset of a trial that said that, mortality was better if you got plasmapheresis, whereas the overall trial was negative. As we know, it was no added value on average for people in either group of getting plasmapheresis or not. So that being said and done, what I would say is if someone's pretty sick, their creatinine has already risen when we're starting to treat them, and they have a very active urinary sediment, we can't get near nephrotic range proteinuria all better in a few months. But we can see it going down by 50%, another 50%. We can see the red cell casts, if you're smart enough to look for them, fresh urine, and actually someone spinning it and looking. But the red cells in the urine, we can see go down more quickly than the proteinuria fully resolving. And I want to see that creatinine going down in the right direction. But if someone presents with a creatinine of, say, 280, and we don't know any past creatinines, it could be that their creatinine clearance is less than 10, and we don't know, because your creatinine is going to take a day after day after day to double. So we don't even know if you have a GFR at all yet, even though you'd say, well, that creatinine could be compatible with long life if it stayed there. Of course, you want it better. So I think, in other words, I think a lot of what I'm trying to answer is I make it up, this gestalt. I don't think I can say better than that, but it's true, right? We got to be honest about stuff. So I will gladly switch to Cyclo to Ritux, or Ritux to Cyclo, in people where I feel like we're not going fast enough or fully enough. Like, we do want to be VAS eventually of 0, even though that's arbitrary too, because it doesn't count every single manifestation. Arielle, tell me the data and what you would think you would do instead.
Well, I don't know if we have, because unfortunately the way most studies have been designed, originally we were sort of not able to consider somebody as being in remission until 3 months had passed. So then how can you compare two treatments to say, one gets you in remission in 1 month and one gets you in remission in 3 months, when you're only going to really arbitrarily say that someone's in remission at 3 months? I think that is changing, and there's an outcome in Advocate, the Avacopan study that looked at remission at 4 weeks, I believe. But in order to do that, you have to have assessments very frequently. And, we do that in usual care, but in trials, they don't often seem to have endpoints very early on. So Yeah, I at 3 months is when, if they're still definitely having active manifestations. So if we see that there's still red cell casts, for example, still a high amount of proteinuria that we don't think is damage. And so that's when it's helpful to see what the kidney biopsy showed. If they come in with a creatinine of 400 and it's all sclerosis, then I don't think we're expecting it to get better after 3 months. But if there's just a lot of active crescents and active inflammation, then maybe we want to be more aggressive if they haven't had the response we'd like them to have after 3 months. But the other question we have is if somebody's sick in the ICU and they're still on the ventilator after 1 month, and that's when we sometimes get impatient in that setting. So I think so far I've been dealing with it on a case-by-case basis, to be honest. And I think what we don't want to see is deterioration for something you could attribute to vasculitis. I think that would definitely push me towards changing the treatment strategy. But it depends on a number of different factors, I think, how young the patient is, how much more immunosuppression I think they would want, what the goals of care are, what else has been tried. And but it's a very difficult call to make when you have somebody who's really sick and it hasn't been 3 months yet.
I agree with both of you. I think it's a really difficult determination. It is my gut instinct that well, in my review of the literature at least, we do not have those time points. So there is not a great trial evidence that's like, oh, well, we assess them every day to determine if they were in remission. There is no such trial. And so the comparison of the two medications, we just don't have close enough time points to determine speed of remission. So unfortunately for now, it's anecdotal and we do our best. But even in the Cyclops trial, which was IV versus oral Cyclo, patients in remission, it was about 50% at 3 months. So it's a very, it really does take time. So if you get someone asking you at 2 weeks, has the Cyclo, the one that we think is faster, I don't think it's working. You probably, honest to goodness, cannot tell them. And I think that I kind of err on the side of, if they're getting worse despite pulse steroids, and let's say they got Cyclo or Ritux, at that point, I actually wouldn't admit that the medication failed, but I would be happy to add the other one, Cyclo or Ritux, and say this person seems to have particularly aggressive disease. So even if we're changing their curve, the trajectory of their disease, they're still getting worse and we don't have time. I think that's a good person to induce with both. So that's a person in which I would say I'm happy to do dual induction therapy, but I wouldn't yet admit defeat that one of them failed. It might just be too early. You've actually started to mention some of the other important trials. So let's get into some more induction therapy. Let's talk PLEX. So this is a multi-center randomized 2x2 factorial trial. Patients with severe ANCA vasculitis who are ANCA positive, and it assessed these two variables, so standard versus reduced dose glucocorticoids, and PLEX versus no PLEX. Most of the patients were induced with cyclophosphamide. About a third had a creatinine over 500 or were on dialysis. About a little over a quarter had some degree of pulmonary hemorrhage, but only about 9% had severe pulmonary hemorrhage. And the trial was looking at death from any cause or end-stage renal disease, and didn't find a difference on those two variables. So the question then to Dr. Mendel, is there a group of people for whom you feel PLEX is indicated?
Thank you for that question. I think, honestly, and I've said this to more than one person, at the time that we wrote the guidelines, I didn't actually think that there was a subgroup that should be considered for plasma exchange upfront. And, the way that the recommendation that we wrote and the CanVasc recommendations is written is that sort of it's not your first line treatment kind of period, just because there's not, because of this sort of quote unquote negative endpoint in PLEX. I do think, so there was a bit of a medical reversal once that trial came out, and I think many people stopped using plasma exchange altogether. And I think that more recently, I believe the pendulum is swinging a little bit back again. And this is because of the meta-analysis that Dr. Walsh did with all the other prior plasma exchange trials, specifically looking at the question of need for dialysis at 1 year. And when you synthesize the available data, it does look like there is a benefit to preventing the need for dialysis at 1 year. And what I thought, was maybe obvious to some people, but I thought was kind of interesting is that the degree to which plasma exchange is useful depends on how bad your kidney function is in the first place. So if your kidney function, if you're, and it's actually more what your risk of having end-stage kidney disease is in the first place. But we know that if you come in with a creatinine of 500, that your risk of developing end-stage kidney disease is, I think, over 25%. And so you're going to get the most bang for your buck with plasma exchange in this type of a person. And I think the number needed to treat is only 7. Mm-hmm. Whereas if you treat somebody with a creatinine of 200, where their chance of having end-stage kidney disease is quite a bit lower, you need to treat 1,000 people with plasma exchange to prevent one person from developing end-stage kidney disease at 1 year. Mm-hmm. And, I think many people say, well, what about, that's only looking at 1 year, but, later on, maybe it doesn't make a difference. And I think part of the problem is most of those studies, the common endpoint to do the synthesis is at 1 year. PLEX had a median follow-up of 3 years, but I think it's the trial that followed people for the longest. So it's hard to synthesize data with other studies looking at longer time points. But I think probably we can extrapolate that the better your kidneys are at point A after 1 year, the better they might be after 2 years, I think. So that's one thing that I would say. And, I think you might talk about, what is some of the downsides of plasma exchange? So they've also, in that same meta-analysis, found that you actually have the same number needed to harm, about 7, with a serious infection. And so that's definitely something to consider. And I don't think they've figured out exactly why you have a 26% increased risk of infection if you get plasma exchange. It doesn't seem to be line-associated infections. So I think that needs a little bit more investigation, but it does seem like, maybe overall serious adverse events, there's also a trend towards, I think, more serious adverse events in the group that got plasma exchange. So, there's something there. And I think back to your original question, which is there a subgroup that you would consider giving plasma exchange to? I think, now that, we consider this meta-analysis, and if we consider some of the recommendations that have come out, I think from EULAR and maybe KDIGO, I think that in somebody with very bad kidney function where, they give a cutoff of 300, but somebody with very bad kidney function, where we think that plasma exchange based on this data might make a difference in some people, that's the type of person I'd consider it in, as long as I didn't think that they were going to for sure die from an infection. And sometimes that's, the biggest problem we have now is actually predicting who is going to have that severe infection. So sometimes it's actually just about talking with the patient and getting what their preferences are. Interestingly, Dr. Walsh also looked at patient preferences with respect to this. And he did, he presented patients with their risks of getting a severe infection and their risks of needing dialysis. And I think about 30% of people across the board still chose plasma exchange no matter what. But they did find that the people who chose plasma exchange were more often people who had had dialysis requirement and had received plasma exchange, which is a little bit interesting to me.
Janet, what's your take?
So can I put it in a different way? Yeah. So, I mean, we have a really good RCT. PLEX showed no difference. It's a long RCT. It was presumably powered for superiority, so not for non-inferiority, but that'd be better. And it wasn't better. And really, when they look in the subset of those patients, it does seem like the small, that 9 or 6 to 9% that had severe pulmonary hemorrhage, like not just a little bit of pulmonary hemorrhage, but the real thing, that they did do better in a sub-analysis. But overall, there was no difference. And the way, like if I were a payer, well, I'm not, thankfully, probably, or I wouldn't pay for a lot of things maybe, but I'd rather have that I could use avacopan for my patients and forget the plasmapheresis, because it's already, plasma exchange is already a large, well-designed negative trial. And I realized that our heart and trying to, like someone really sick, we want to throw everything at them. But on the other hand, from even a cost effectiveness, it's a very, very expensive therapy. Maybe I'd rather have something that's actually proven better than standard of care. But that's my take, being very pragmatic about it. Our nephrologist loved plasma exchange, and we're part of PLEX. And we still see people getting plasma exchange. Sometimes we're not exactly sure why, to be quite honest. And when we call them on it, they go, well, it's a feeling. They go, well, this patient's really sick, so we want to try everything. But it's not, and it's eminence-based, sometimes historically based on their past experience, but it is not evidence-based. So, I mean, I just find sometimes, do we need more studies when an RCT is really, in many ways, put the answer as a no, don't do it.
And I'm just going to give...
asking.
I'm going to give some numbers to what Dr. Mendel has already said. So she kind of nailed it based on that meta-analysis. If you had a creatinine between 300 and 500, your risk of end-stage renal disease was 7.5 to 25%. If your creatinine was over 500, your risk was over 25% of end-stage renal disease. And PLEX, in that highest risk group, where, as she said, that's where you're going to see the most benefit, PLEX reduce your risk of end-stage renal disease at 1 year by 16%, but increase your risk of infection by just under 14%. And so, like, I think that that's important, which is that you could say, objectively, the best, evidence that we have is that there is a group of patients for whom we can keep them off dialysis at a year. We can do that. The benefit seems to fade by the 3-year mark, as far as we can tell, and as good as the data is going to be for a while. But there's a legitimate risk. Serious infection is something that perhaps we as clinicians have a better sense of what that looks like and how horrible that is compared to perhaps patients who haven't had one. But anyways, I struggle with this because, like, if it was me, I'd say, like, oh, well, maybe I can beat that serious infection because I'm, like, otherwise healthy to start. So, like, maybe I don't get that risk, but I get all the benefit of maybe not being on end-stage renal on dialysis. And that's why I kind of love that he included patient input. And so in this group, that's kind of what I do. I talk to the patient, and obviously if they're capable of having this conversation, they're pretty sick at this point. And I talk to them and I give them that data. So this is something where I think that's actually very much a shared decision, nephrology, us, patient, but reflecting kind of those numbers that you mentioned, I think is kind of the best that we can do. So no, I would not PLEX everyone, and I wouldn't even PLEX everyone with a creatinine over 500. I would have a conversation with them about that, because the benefit is, even at its absolute best, small. It's not nothing, but it's not a massive benefit. Is that crazy? You can say yes.
No, I think that makes a lot of sense. And I think, it'd be great if we could show that avacopan also reduces the need for dialysis. I mean, we're hoping to study it in patients with severe kidney disease that were excluded from Advocate. Mm-hmm. And I'm sure we'll talk a little bit about avacopan shortly, but there does seem to be a benefit in terms of kidney function. So that's something to consider as well. But yeah, I think, I've heard Dr. Welsh say that he wishes that he hadn't chosen a composite outcome of death and end-stage kidney disease, because in this particular case, it seems like they're kind of going in the opposite direction. The reason that the net effect was negative is that you had more deaths from infection, or at least that's the way he's explained it to me, even if you manage to reduce the risk of end-stage kidney disease. And so, I think that also teaches us that it's important to get the end point right when we're designing a study, so that it'll make things less confusing when we're interpreting the results.
We are going to get to Advocate in just a moment, but the other half of the PLEX trial was the reduced dose taper. And it's kind of the opposite question. Who wouldn't you use a reduced dose prednisone taper in?
That's a good question. I think all of us, or, many of me and my colleagues, we might shy away more from that, especially that initial jump that the PLEX taper does from 75 to 40 milligrams. When somebody's still hospitalized and actively having hemoptysis, pulmonary hemorrhage, I think, pulmonary hemorrhage tends to be kind of this thing that doesn't like when you take away the prednisone, but it's all anecdotal. And so this is, maybe a group that I tend personally to deliberately go a little bit more slowly. So when we think about the PLEX trial, they compare this low dose taper regimen, which we know very well, with this sort of what I would think is a higher than standard prednisone taper. If you look at the taper they used in RAVE, it's actually much more, they taper prednisone much more quickly than what they did with the high dose PLEX taper. So it's not necessarily that if I'm not using the low dose PLEX regimen that I'm using the high dose PLEX regimen. I don't tend to do that, but it would be something in the middle, I suppose.
How about you, Janet? What do you think? Anyone where the evidence in the trial was they were equivalent?
I guess what's so weird is in everything we say steroids are bad, but interestingly, in your active induction part of GPA, not enough or too quickly tapering is actually worse for things like infection sometimes, but for not getting remission, I can't tell you about relapse because they're not always looking that far out to look at whether the rates are way different on relapse. So where, I guess I'll go the other way, where would I want to rapidly taper? I think we'd all agree if someone's already like a diabetic, whether they're type 1 or type 2, osteoporosis, like all the usual steroid things, or we'd like to avoid more and tons of steroids if possible. But I think we sometimes have in mind, or at least I do, I'll have in mind, okay, I'm going to try a rapid taper. But if something's bumping upwards, and I think it's related to, might not be, but a cause and effect of I've gone down, now the creatinine's gone back up, not the urinary sediment, because it's not going to respond that quickly to a change in steroids probably. But then I might say, okay, now I better slow it down. So in other words, I think there's a lot of room for kind of using, I guess, your common sense scope to kind of look and say, where am I at? What's happening with the patient? I made a big jump downward. They're still fine. Great. Or now they've got, their leg ulcer. Right. So now I got to go back up. Yeah. I think we individually look, are you one organ or many organs, and what's happening with the worst of the organs and then what's happening with the rest. So in other words, I'm hedging.
Janet, I think if I may, you really are kind of reflecting the real world anxiety about a rapid taper. And Dr. Walsh did an interview with Mike Putman on his podcast. And he made a good point, which is like, this is a huge trial. And it is our best, like one of our best evidence comparing different tapers. There are other trials, but this is an excellent, well-designed trial, essentially. And they used that taper in very, very sick people. And so if you use a taper outside of that, essentially, like that's that's non-evidence based. If you use the tapers inside the trial, that's evidence based. Those aren't his exact words, of course, but I think that's an interesting perspective. But I think anxiety about that low taper is kind of part of, what is then reflected in Nagel and the French group did a real life use of the PLEX taper retrospective. And they kind of indicated that they had a different outcome for their trial, but, they had, looking at the PLEX outcomes, they didn't find a major difference between the rapid taper and the standard taper. And there was this subgroup of this retrospective study that said that rituximab-induced patients had an increased risk. And I think that plays on our anxiety. And I also have the anxiety. So I've kind of slotted it in my head as if someone was underrepresented by the trial, that frees me up to use a different taper. If they are well represented by the trial, then I really do try and use the more rapid taper to try and spare them the steroids. But I have I do have a low threshold to go back to a quote unquote more standard taper. And that's kind of as comfortable as I can get until until someone solves this down the road. All right, we're going to take a break here and rejoin this conversation in our next episode, part 2 of our conversation about ANCA vasculitis management with Dr. Arielle Mendel. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag our Twitter account with your question at CRASCRRheum. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Erin Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening.